I will speak about all layers of the thorax. Last time I presented for you the thoracic wall. Yeah? We spoke about breast, we speak about borders. Today we will continue on the second part of the lecture, will be about the cavity. We will start to speak about thoracic cavity also. Yeah, by the way, guys, this downloading slides from previous lecture, please. I told for the previous group to inform you that I need some update on the slides. It is possible to is possible. Well, starting from tomorrow, we'll have our midterm exams, guys. Maximally please, fast, make the work. This is the main my problem which I have during this midterm. Then one person go outside, another person sit down and wait, will come or not. I will strongly punish for such kind of situation, guys. I will explain you why. Because during one day I have 2, even 3 groups which will pass the midterm examination. If you don't want to work up to the 6, 7 o'clock by PM, you must do it much more quicker because we have another works also. Let's say then one person go out from my group, immediately, next one, immediately it means during 1 minute, not more, will enter in my room. So you will pass it in my room, So your classroom, you can use like the storage place. You can take the key, you can put your bags, close it, but majority of the students will be near of my room, be near of my door. To not lose this time, then one is come out to be exactly entering my room. You understand me or not? Please do it, otherwise we will prolong our class up to the evening. And before I will start my lecture, sorry, little bit about your individuals. A little bit about your individuals. Just 1 minute. A little bit about your individuals. Guys, don't mail me 7 times during the day. Sir, do you check the work or not? Is it okay or not? That is abnormal. This work checking, guys, it's not the drinking of the coffee, you know? That is the difference. We need the time. That is long work. Then I will finish, I promise you, I will inform everybody about your marks and about your mistakes. But it is approximately need from me to check all these works of all 4 groups near 1 week. They say, please, if I will show for you my messenger, 75 students ask me, do you check it, do you check it, do you check it? To be more serious, guys. Is it understandable? Then I will check, I will tell you all results. I will not keep it for myself, believe me. Unfortunately, I'm not sure that in this week I will have the time to give you the topics for next individual due to my very strong busy in your classes. In your classes, I will achieve your midterm exam. So what I ask you, head of the groups, just write me how many topics you need according to the number of your students in the group, and I will send it. Among of these topics, you will choose which is more or less better for you. Just every student must to take separate works. Don't copy, don't.
So, is there a jacket on the second last row on that?
Go check. Go check. Let's say don't take the separate works, please. Everybody must to have its individual work. Is it understandable for you? Very well. If you understand it, let's start. Write please the name of the topic. It is the all layers of the thorax. And pay attention, guys. Which layers we call all? That is the layers which doesn't anyhow, not by location and not by function, connected with upper extremity. That's it. Layers which we studied before, or anatomically, or functionally, have connection with the upper extremity. What does it mean? Anatomically, skin from the thorax past to the upper extremity. Or functionally, pectoralis major make the movement, adductional movement of the upper extremity. Now we will speak about structures which not anatomically, non-functionally, doesn't connect it. That is the cause why we call them all layers. It means they belong only to the region of the thorax. This is right, please. All layers of the thorax, this is the layers which end anatomically and functionally connected only with the thorax region. Connected only with the thorax region. And they divided into two big groups. Group number one, it is the bony skeleton of the thorax. In the brackets, write please, sternal bone, 12 vertebrae, thoracic, and 12 ribs. That's all, guys. Don't include it inside of them. Not the clavicles, nor the scapulas, because they functionally connected with the upper extremities. This is not the all layers of the thorax. Right, please. Group number two, it is the soft tissue structures. In the brackets, right, please, the muscles and the fascias, which is functionally connected with respirational action. In the brackets, right, please, this is the intercostal muscles. This is transverse thoracic muscle. This is endothoracic fascia, which is cover all wall structures from inside, and which is enclosed the mediastinum and forms the fibrous cavity of mediastinum. So 1 minute attention now, look in the picture, please. This is the structures which is belong to the all layers of the thorax. So you can see the bony skeleton, which is called the thoracic cage. And inside of this thoracic cage, as you remember, we have two cavities. One is double. We call it serous cavity. It is right and left pleural spaces. And one it is single, which is between them, and which is called the fibrous cavity, mediastinum. So what is included in soft tissue? That is the structures which is functionally connected with the action of the respiration. It doesn't make any movement of the extremity. Is it understandable for you? Very well. Write the name of the next topic, please. It is intercostal space. Intercostal space. Right, please. This is the space which is formed between intercostal muscles, external and internal, and between the ribs. Borders of the intercostal space. From upwards, it is inferior border of the upper rib. From downwards, it is the superior border of the lower rib. From in front, it is external intercostal muscle. And from behind, it is internal intercostal muscle. Point number one, right, please. Anterior border of the space, external intercostal muscle. It is originated from inferior margin of the upper rib in front of the costal groove, and it is inserted to the superior margin of the lower rib, and it is inserted to the superior margin of the lower rib. Right, please. Muscular fibers pass from up to down and from the laterally to the medially. Up to down and from laterally to the medially. Right, please. In the anterior wall of the thoracic cage, it is replaced by the intercostal membrane or aponeuros in the place of transition of the ribs into the cartilages. In the place of the transition of the ribs into the cartilages. Open the brackets on the right, please. Approximately in the level of the middle clavicular line. Approximately the level of the middle clavicular line, in the brackets right, please, up to 2 centimeters medially to it. Up to 2 centimeters medially to it. 1 minute attention in the picture. Again, this is synthetical pictures, guys. Then you asked me, also today I spoke about synthetical. Now what I am doing, you can see in 2 different sides, you can see 2 different levels. In the right side, it is level of external oblique, external intercostal. In the left side, it is the level of internal. So you can see that external one in anterior wall has 2 colors, white and red. White one, it is aponeurotical or membranous part. Red one, it is the muscular part. For the left side, vice versa, you can see completely red structures in the anterior wall. But then you will look to the back, you will see that it's aponeuros or membrane located in the posterior wall. They say external oblique has the membrane in anterior wall of the thorax. Internal oblique of the posterior wall of the thorax. Of course, guys, write please the function of in external intercostal muscle. It is inspiration, because then it is constricted, it is lift the ribs to upwards. It is lift the ribs to upwards. Now everybody please, put your hands in your thorax and make the deep inspiration. You'll see that thoracic cage is not only enlarged, stand bigger, but also the ribs is lift from down to upwards, vice versa. Then you will make expiration. You will see that not only your diaphragm goes to upwards, but also your ribs descending to down, and it's make the narrower the thoracic cage. So remember, please, right, internal intercostal muscle. You know, in normal real anatomy, there are internal and inner muscles. But we will simplify, we will describe just one muscle, yeah, because this is not the anatomy for us. This is topographical. Right, please, it forms the posterior wall of the intercostal space. It is originated from the lower rib upper border. It passes from down to upwards and from laterally to the medially. from down to upwards and from laterally to the medially, and it is inserted to inferior border of upper rib, inferior border of upper rib, deep to the costal groove. This deep is usually confuse you guys because we speak about circular structure. Minute attention. Why I don't say in front or behind? Everything is simple, guys, because in anterior wall it will be behind, in posterior wall it will be in front. But in both cases it will be deep. Do you understand me? That's like if my hand, it is the rib, internal intercostal, and in the inferior margin of the rib, there are sulcus costae. Internal intercostal attached to the inferior margin of the rib above. In anterior wall, it attached behind of the sulcus costae. In posterior wall, in front of the sulcus costae. But in both cases, it is deep to the sulcus costae. Idea is understandable for you. So remember it, please. Once again, muscular fibers goes from down to upwards and from the lateral to medial. In the brackets, right, please. Absolutely straight cross angle with the muscular fibers of external intercostal. With muscular fibers of external intercostal. Idea is understandable for you guys. Just one internal one start from down and come to the upwards. Now look, it comes from laterally to the medial. Previous one also passed from laterally to the medially, but it starts from up to down. Let's say look to me. My right hand now show the muscular fibers of internal intercostal. My left hand show the muscular fibers of external intercostal. Do you see? And you can see that they cross each other in 90-degree angle. That is prove us that this is antagonist muscles. Muscles with opposite functional units. Now, right, please. Inside of the, first of all, we forget to mention that internal intercostal, in the posterior wall of the thoracic cage, forms the posterior intercostal membrane, or we call it also internal intercostal membrane, both names is useful. Let's say external has external one, this one has internal. Let's say external we can call anterior or external, posterior we can call posterior or internal. Both names is useful. Now right, please, it is located approximately along the paravertebral line in the level of the costal angle. You know, costal angle, it is the place of the changing of the body of the rib to the neck of it, the narrowing place. Let's have 1 minute attention to me, approximately in the level of the costal angle, you can see the paravertebral line, and according to this paravertebral line, medially to it, internal intercostal become to the membranous structure. I said this is very important to be mentioned. Now, right, please, inside of intercostal space, we have intercostal neurovascular bundle, which is presented from up to down by VAN. Vena intercostalis, arteria intercostalis, and the most lowest structure, it is the nervus intercostalis. Nervus intercostalis. Right, please, there are 12 intercostal neurovascular bundles. Last 12th one we call subcostal, because it's located not between the ribs, but the below rib. Right, please, origin of the structures. Intercostal arteries divided into two groups, anterior and posterior intercostal. Right, please, anterior intercostals originated from the thoracic interna, 6 uppers immediately, 6 lowers from branch of the thoracic interna, which is called arteria muscula phrenica. Arteria muscula phrenica. In the brackets, write please, the diameter of the lowest 6 is lesser than the diameter of the upper 6. By the way, I want to remind you that in the reality, thoracic interna in each intercostal space gives not 1 but 2 vessels, yeah? Second lower one we call the perforating branch, yeah, which goes and make the anastomosis with the collateral branches of the posterior intercostals, as you remember, yeah? And it is located, if main one or superior one located inside of the costal groove, perforated one goes deeper. It is perforated internal intercostal and goes into the posterior mediastinum to make the anastomosis. But to simplify, we will just call anterior and posterior intercostals without dimension of this specific. All right, please, posterior intercostal arteries, except the first and second, originated from thoracic aorta, and they have opposite direction to the anterior. Anterior is passed from anterior to posterior, medial to the lateral. Posterior is passed from posterior to anterior, medial to the lateral. That's why one is passed from anterior wall to the direction of the middle axillary line. Second is passed from posterior wall towards the direction of the middle axillary line. Right, please, the first and second posterior intercostals presented by branchings of arteria intercostalis suprema, which is the branch of truncus costocervicalis, from the second portion of subclavian artery. From the second portion of subclavian artery. I think it is understandable for you guys, and due to the specificity, of course, and venous drainage will be different. Venous drainage is different, guys. Remember about, please, if you will look to the upper 2 veins, which is located in first and second intercostal space, you will see that they drain not inside of the azygos and hemiazygos, but they drain into the subclavian venous system. This is very important to remember, guys. Is it understandable for you? Anterior, yeah, will be drained into the azygos, hemiazygos, but posterior too will be drained immediately inside of the subclavian venous system. Right, please, the venous drainage. Intercostal veins drain into 2 unpaired venous systems, which is located in the posterior mediastinum, and which is called vena azygos and hemiazygos. Both these veins originated by ascending lumbar veins, which from retroperitoneal space become to the posterior mediastinum. Go, please. Who gave you permission? That's why you ask me now. Just now, today, you decided to go to this hospital. Why you can't, for example, mail me yesterday? Why in the time of the lecture? Okay, go, but I will keep you absent. Unfortunately, that is the problem, guys. I want to be helpful. You can go. But understand me, guys. After, if somebody will come and check and see that in that time I put the present for you, I will have a big problem. Okay, right, please. On the right side, along the right margin of the thoracic vertebra, we have the azygos vein. And it is located strongly in front of the anterior surface of the costovertebral joints. Costovertebral joints. From the level of approximately third rib up to the level of the 12th rib. Right, please, right intercostal veins drain inside of it. And in the level of the fourth up to third 5 thoracic vertebrae, from fourth up to the 5, yeah, fourth, 5, third, yeah, differently. It is passed from right side to the left side, and it is drained into the superior common vein. Why I don't give you strong position, guys? Because we can have variations. Majority of the literature say that it is level of the third thoracic vertebra, but sometimes it can be one vertebra higher or one vertebra lower. Let's say middle average position, it is the level of the third. That's why I say at the level of the first and second, it was absent. It is started from the level of the third, and along the right margin of the costovertebral joints, it is descending to down. By the way, as you can see in this picture, it is continuous to the retroperitoneal space. But here we call it not the azygos, but we call it ascending lumbar vein. Azygos, it is from the region of the thorax. Below the region of the thorax, we call it ascending vein. By the way, open the brackets on the right, please. Due to its origin from ascending lumbar veins, it forms the cava-caval anastomose in the level of the diaphragm. In the level of the diaphragm. What does it mean, guys? Minute attention. You understand that the lumbar veins drain inside of the inferior caval venous system. And just now we say that azygos drain into the superior caval venous system. Of course, in the level of the diaphragm, it means the border between abdominal region and between the thoracic region, we will have the cava-caval anastomosis. Very important, by the way. In the future, then we will study abdomen. We will mention the necessity of that. I want to say that normally we don't use all these anastomoses. But if inside of any venous system will be hypertension, our blood will try to shunt it and goes to another system. For example, from the system of the inferior caval to the system of superior, or portocaval anastomosis, from the system of the portal to the system of the caval. By the way, portocaval anastomosis, this is the most clinically important form of the anastomosis. This is between portal venous system and caval. I want to remind you that this anastomosis we have and in the walls and in the cavities. For example, let's remember that in the cavity portocaval anastomosis, we have just in the border between esophagus and the stomach, inside of the anal portion of the rectum, in the region of the right kidney, suprarenal gland, in the anterior abdominal wall, it is the region of the umbilicus. I want to remind you that here we have some pathological problem which happen in case of portal hypertension, which is called caput medusa. What is the caput medusa? You study from pathophysiology. Let's imagine that the person has the portal hypertension, for example, cirrhosis of the liver. Venous blood cannot be normally passing inside of the portal venous system. By the way, can you remind me what is the main function of our portal venous system? Why we need to have the portal system? From which regions of the human body blood is accumulated inside of the portal vein? And for what? Please. Maybe you? That is anatomy, that is physiology, that is pathanatomy, that is pathophysiology. But from anatomy and physiology, you achieve all this information.
Cleansing of blood
What?
from lower organs.
Lower organs.
In the
It is in the floor. Where are you? Lower organs. What is the lower organs? There is some new anatomical names. Lower organs. Upper organs, middle organs, lower organs. What does it mean? Maybe you will try to help me. What is the lower organs? Abdominal organs? Are you serious, guys? Friends, today I have the attestation of the 6-year students. And approximately for 20%, I didn't put the mark. It means they will not have permission to pass the state exams. If you don't want to repeat this future, then you will come to the 6th year. Today, you are responsible to resolve this problem. 6-year students, is impossible to resolve it. Do you know why? Because the deficit of the knowledge is so big that it's impossible during this not half of year, 1.5 months up to the state exam to improve anything. It is impossible. You have many, many years. You can try now to improve your problems. Do it, guys. That's awful to not know that from all gastrointestinal tract, except your esophagus and except your anal portion of the rectum, blood is accumulated inside of the portal venous system. Why? Because it should go to the liver for detoxification. During this digestive functions, a lot of the toxins is absorbed inside of the blood, and your liver is worked like the filter. It makes the filtration of this blood and detoxification and elimination of some structures. There's a portal venous system responsible for collection of the blood from gastrointestinal tract and provision. Why not from esophagus? I say from all organs except esophagus and the anal part of the rectum. Why? Awful, awful. Because I spoke about absorptional qualities. Do you know any absorption in esophagus? Do you know any absorption in anus? That's why blood from this region doesn't need to be detoxified, guys. Friends, to be a little bit more clever, please. To revise, please, that is not hard. But let's imagine that inside of the liver there are, for example, cancer. Or there are cirrhosis of the liver due to the alkalism. Portal vein inside of the liver will be compressed. And generally, no any chance for all the blood from the guts to go into any place, because portal system is compressed. What is the single choice? To find anastomosis, connection between his portal system, he has high pressure. His colon system, inside of colon system, there are normal pressure. I am anastomosis. If this portal system will be compressed, blood from the portal system through E will go to the colon system. Only in these critical cases, anastomosis will be used. Remember, please, normally we don't need them. So normally this anastomosis doesn't work. We should have two situations. Situation number one, gradient of the changing pressures. Situation number two, gradient of the changing gases. If concentration of the gases is changed or pressure is changed, this will be the signal to open this anastomosis and to make the circulation among of them. As in one case, they will start by the irritation of the chemoreceptors. In another case, irritation of the mechanoreceptors. Remember, guys, and what will be happen? Of course, if the huge amount of the blood from him come to me, I will be deleted. This deletion in the physiology we call compensation of mechanism. I will delete to provide this blood from one system. But again, physiology teach you that any compensation have the borders. And finally, compensation come to decompensation. What will be happen with me? Possibly rupture and bleeding. Let's say, for example, for the people with portal hypertension, it's very usual esophageal bleeding. Why? Because we have portocaval anastomosis or hemorrhoidal bleedings. Here also portocaval. They will be enlarged, but any enlargement have the borders. Finally, we will have rupture of the vessels, formation of the bleeding. Same we can have in these paraumbilical veins, which is surrounding. Again, anatomy, you can ask me how here this anastomosis forms. Just remember, after several months, then in September, we will study topographical anatomy, we will speak about anterior abdominal wall. Here we have the round ligament of the liver. What do you remember about round ligament?
Of the liver.
Yeah. What is it? Anatomy, embryology, histology. What is the round ligament of the liver? You see, guys, I interrupted now my lecture and I check your knowledge from previous subject because a lot of very big, beautiful, but absolutely, how I can say, unconsciousness persons didn't understand that during every year of medical university education, you should collect it, not the problems, but knowledge. This you're collecting knowledge, it is the base for the next subject's education. If you don't achieve this base, you cannot continue your education because any next subject needs to have some precursor knowledge. So it's easy, dear. Then we are remnant. Then we have fetal life. We have very important structure which is called umbilical vein. Umbilical vein provided arterial supplement for fetus. It is started from placenta and it is finished inside of the liver. Why inside of the liver? Because it forms here anastomose with inferior caval vein. All arterial blood of the fetus by the umbilical vein come to the inferior caval vein. From inferior caval vein, it is come to the right atrium, and 80% of this blood by oval aperture from the right atrium come to the left atrium and goes to the aorta. What about 20%? It goes to the pulmonary trunk and by the aortal duct, ductus aorticus, or otherwise we call it bottle duct. It is passed from pulmonary trunk to the aorta because lungs doesn't work for the fetus. Friends, this is not my subject. I studied more than 35 years before. If I remember, why you didn't remember? You studied half of semester before. It is fetal circulation of the blood. Then this dear umbilical vein is abstracted after the child was born. It will become to the round ligament of the liver. Round ligament of the liver, it is the remnant of umbilical vein. But this umbilical vein doesn't close completely. Inside of this ligament, there are very small paraumbilical veins, which is drained into the portal venous system. That's why surround of our umbilicus, we have formation of portocaval anastomosis. Why so longly I spoke about it? Because inside of the thorax, between thorax and abdomen, we have also venous anastomosis. And this is cava-caval anastomosis, between the system of inferior and superior caval veins. Right, please, in the left side, or by left margin of the vertebra, we have hemiazygos and hemiazygos accessorius veins. Right, please, hemiazygos vein, located in the level of 6, 7, 8 thoracic vertebrae. Then it is turned from left side to the right side and drained into the vena azygos. Minute attention into the picture. This is the level of our diaphragm. This is vena hemiazygos, 6 and 7 approximately, you can see. Then it is pushed from left side to the right side, and in the level of the same 6-7 thoracic vertebrae, as you can see, it is draining side of the azygos one. Right, please, in other portion, in the left side, we have hemiazygos accessorius one, hemiazygos accessorius, which is collected upper intercostal veins. Again, except the first and second, which we say drain into the subclavian venous system. Here are two situations, guys. I want again remind you anatomy. Hemiazygos accessorius can be drained into the azygos one. Usually it is the level of the fifth approximately thoracic vertebra, or it can be drained into the hemiazygos. Both situations is possible. Accessorius can be drained immediately into the azygos or into the hemiazygos, which again drain into the azygos. Finally, there are the drainage of left-sided to the right-sided. Right-sided into the superior caval venous system level of T3. Idea is understandable for you. Very well, right, please, intercostal nerves. It is originated from the 12 segments, thoracic segments of the spinal cord. They have mixed fibers and motor somatical and vegetative and sensory fibers. They pass inside of the intercostal neurovascular bundle, and they have the lowest position inside of it. Right, please, posteriorly, from the level of the costal angle up to the level of the vertebra. Intercostal nerves separated from parietal pleura by internal intercostal membrane and endothoracic tissue. Make attention in the picture, please. You understand, guys, that in the posterior portion here, between parietal pleura and between intercostal nerves, we will not have the muscles, because as you remember, internal intercostal muscle in the posterior will become to very thin posterior intercostal membrane. And so what is the problem, guys? Distance between intercostal nerves and between parietal pleura will be very thin, because good developed muscle from the level of the costal angle up to the level of the vertebra will be absent. Because internal intercostal, again I tell you, in the posterior wall, become to very thin membranous structure. What about this? If is pleura, this is membrane, I am the nerve. If he will be inflamed, which is called the pleuritis, this inflammation very simply through the fissuras, which is located in the intercostal this membrane, can be spread to me. And it will give the irradiation of the pain along of all intercostal spaces. And this is understandable for you. So remember about it, please. This is very common signs of inflammations of the pleura. So we see the inflammation of the pleura is irradiated along the intercostal spaces. Is it understandable for you? Very well, right? The next layer is the transverse thoracic muscle. It is started from the lower half of the sternum, and it is inserted obliquely to the second up to the sixth postachondral joints. As a fibers is passed from down to upwards, from medially to the lateral. Conclusion is simple, guys. If it is started from down to upwards, during its constriction, ribs will be descended to down. That's why it is exhalational muscle, because we know that inspiration, vice versa, lift the muscles to upwards. That's why this will descend the muscle. So-called active exhalation. You know, exhalation happens by two phases. Generally, normally in the rest, we use the passive exhalation, then the diaphragm goes to upwards, passively it is increase the pressure, and air is evacuated from the lungs and come to outside. But then you make the hard physical work, you need to use a forced expiration, yeah, to make maximally quick the inhalational movements. That's it. You will start to use the muscles also. And also it is muscles which is located inside of the thoracic cage. This is transverse thoracic muscle. Idea is understandable for you. Right, please, the last layer, hurry up guys, and it's short. Last layer it is endothoracic fascia. Endothoracic fascia cover all thoracic wall from inside and in the border between pleural spaces and mediastinal, it gives two septas from anterior to posterior. From anterior to posterior, which is separate, which is covered from inside mediastinal pleura, and make the separation of the mediastinal from the all sides. Right and look to me. You and you, please come to me. Hurry up. Friends, time is short. Stand up towards each other. Look to each other. My two friends, it is two pleural spaces. As you understand, the medial part of the parietal pleura will be called mediastinal pleura. Yeah, I am the mediastinal. I am located between them. Now let's imagine that we are covered by all these thoracic walls. We are inside of the thoracic walls. Yeah. Now these thoracic walls from inside covered by deepest layer of proper fascia, which is called endothoracic one. Is it possible? Come stand up in front of me. You come stand up behind of me, please. Hurry up. Now our dear friend who is in front of me, it is sternum. Friend which is behind me, it is the vertebra. From inside, look, they doesn't belong to the walls. This is the cavities. Wall will be here. Look. Let's say they will be inside of the cavity, not inside of the wall. Now, these walls from inside, covered by endothoracic fascia. Now, from two sides of the sternum or from two sides of the vertebra, now two septas will originate, like my hands. These septas will cover the mediastinal pleuras from inside. There's a space which will be between two pleural sacs will be surrounded from all the sides by the endothoracic fascia. That's why this middle space will be called fibrous cavity. From all the sides except upwards. Upwards, we don't have a real border. That's why spaces of the neck communicated with the superior mediastinum. From downwards, the same endothoracic fascia will cover my floor, the diaphragm, except the tendinous center of it, the place of attachment to the pericardium, yeah, junction of the pericardium. All other parts will be covered by the endothoracic fascia. Conclusion is simple. I will be inside of the fibrous space, and from all the sides I will be covered by endothoracic fascia. They will be serous cavities, because they forms by the parietal pleura. Sit down, please. I think it is not hard to imagine. Let's say these two septas, which is originated in sagittal plane, yeah, and cover the mediastinal pleura. They separated our mediastinum from the pleural spaces. And this is understandable for you. Very well. Look, guys, this endothoracic fascia cannot be continuous into the abdomen. Why? Because the diaphragm will close. But in the abdomen, you will see evolutionally the same structural unit, which is covered inner wall of the thoracic walls. And it will be called endoabdominal fascia. endoabdominal. That's it, we have endothoracic fascia, and we have endoabdominal. I want to remind you that part of this endoabdominal fascia, which is covered transverse abdominal muscle, we call transverse fascia. Fast transversal, you studied from anatomy. That's an evolutionally it is same deepest layers of proper fascia, but they doesn't continues to each other. Because between them we have the wall, which is called the diaphragm. Idea is understandable. My congratulations, we finished to speak about all layers of the wall and write the name of the next topic, thoracic cavity. Thoracic cavity. By the way, very short time I will need to finish this thorax, in my opinion. Next week, in the practical class, I will explain for you surgeries of the thorax, and starting from next week, we will become to upper extremity. It will be the last topic. Of course, it's much more bigger. So up to the finish of semester, I will speak about upper extremity regions. And that will be 2 topics of your second midterm examination, as you understand. Yeah? Right, please. Inside of the thoracic walls, we have 3 cavities. Right and left pleural, which is serous cavity, and mediastinum, which is between them, and which is the thoracic, and which is fibrous cavity. Which is the fibrous cavity. And when it look in the picture, guys, the anterior thoracic wall is removed. Under of it, you can see serous sacs, which is called the pleural spaces. Inside of pleural space, as I told you before, there are 2 types of cavity. This is the pleural cavity, because this is the space between parietal and visceral pleura. And this is the pleural sinus, because this is the space between 2 different parts of parietal pleura. You can see that lungs is absent here. Remember, please, pleural sinus, it is free space. It is potential space, which can be used for some critical situation that you need to make over-expanding of the lungs, for the over-respiration. But even during the deepest over-respiration, these spaces will not be completely occupied by the lungs. They're bigger than even can be necessary for us. But if you will look attentively between these 2 pleural sacs, you will see 1 more cavity. By the way, from in front, it is partially covered by the pleural sacs. From behind, it's much more open. And this space is called the mediastinum. So remember about it and write, please. Point number 1, pleural sacs or pleural spaces. That is the same. Right, please. This is the potential space, which is located between parietal and visceral pleura. Or between different parts of the parietal pleura. Conclusion. Pleural space dividing into 2 compartments. Compartment 1, pleural cavity between parietal and visceral pleura. Compartment 2, it is pleural sinus between the 2 different parts of parietal pleura. Don't mix these terms. Then we say pleural space is bigger than pleural cavity. Pleural space has 2 cavities. One, it is pleural cavity. Second, it is pleural sinus. So remember about it, please. Now, a little bit attention to me. This is the just revision of the anatomy and physiology. Don't write, but listen. What does it mean, the pleural structures or pleura? Pleura, it is the serous membrane. As you remember, it has 2 compartments, yeah? Connective tissue base and 1 layer of the serous coating, which is fused with this connective tissue base. Serous coating, guys, it is serous cells, which is responsible for primary main 2 functions. Function 1, it is production of the liquid. Function 2, it is absorption of the liquid. There are another functions also, like the immunity functions, like, for example, phagocytor functions and several other functions, yeah, for the plasmacytes, yeah. But primary function is production and absorption. I want to remind you that production rate approximately 10 times less than absorption. That's why we cannot normally have any accumulation of the liquid inside of the pleural space. Inside the pleural space, we don't have any free liquid. What is the free liquid? It is accumulated liquid. What we have inside of the space normally, don't check my patientness there. Look in me, not to the floor, not to the roof, and not to the sides. Do you understand me or not? Don't be any explanation. Just listen. Let's have a look, guys. We have small amount of the liquid, which is located in the surface of the pleura, and which is made lubrication of the surfaces. Amount of this liquid is constant. Why again I tell you? Because absorption is much more higher than production. That's like normally we cannot have accumulation of the liquid. Then there are accumulation of the liquid. It is called pleural effusion, and it is shown pathological condition, which is primary associated with inflammational or hypertensional problems. Look, in case of hypertensional problems, we have formation of the effusion, which is called the transsudat. As you remember, transsudat has very small amount of the proteins. It has very small gravity indexes. Vice versa. Exudat, it is the liquid with high concentration of the proteins. And it is happened primarily in the case of inflammational processes. That's why remember, please, effusion can be transsudative and exudative. By the way, for transsudat, there are two causes of formation. You know it from the physiology. Cause number one, high hydrostatic pressure, hypertension. Due to infiltration of the liquid will increase, or low arterial pressure. If the arterial pressure will be low, blood, water, liquid from the vessels will leave the vessels and will go to the interstitial place. This is physical rule, guys. I am very sorry that you listen first time, but this is the physical rule. Liquid go from the place of the low concentration to the place of the high concentration. That is the physics. Let's say, remember, please, this is the pleura. Parietal pleura, by the way, much more responsible for production. Visceral pleura, much more responsible for abstraction. But in the parietal pleura, there are the special structural units, which is called the stomatas. As you remember, stomatas, it is fissura-shaped apertures, which is located in the parietal pleura and which is immediately connected with lymphatic system. And they can be used for abstraction of some big structural units, some microorganism, foreign body, I don't know, ash, or something like this during the smoking. Yes, you understand. That's that they can make some function which is near to the phagocytose. It's not phagocytose, but it is absorption of the big corpuscular structures, not the liquids. Parietal pleura has very huge sensory innervation, visceral one knob. That's the inflammation of parietal pleura is very painful. Inflammation of visceral or damage of visceral, not so much. Why? Because parietal pleura immediately innervated by intercostal nerves, which has a lot of the sensory fibers. So remember, please, this is the difference between parietal. Parietal pleura, again, anatomy, divided into four main portions, which I tell you in my previous class, according to place of location. Biggest part we call costa sternovertebral, or just costal. That is the part which is covered from inside completely ribs, partly sternum and the vertebra. Why partly sternum and vertebra? Because between them we have mediastinum, I told you before. Inferiorly from the ribs, it is descending to the floor. Floor, it is the diaphragm, and we call it diaphragmatical pleura. By the way, place of transition of costal pleura to the diaphragmatical pleura, we call postdiaphragmatical sinus. Again, I tell you, sinuses, it is transitional places between one and second forms of parietal pleura, not visceral. Postdiaphragmatical sinus, it is biggest and the lowest point of the pleural space. Lowest point of your pleural space, then you are in vertical position, it is postdiaphragmatical sinus. Look to me. Postdiaphragmatical sinus along the middle axillary line come approximately up to the level from the 7 up to the level of the 9 ribs here, or from the 9 up to 10. The size of it is huge, approximately 7-8 centimeters. 7 centimeter space without lines. 7 centimeter space which can be punctured without damage of the lung structures, because normally lines was absent here, but liquid in case of pathological condition. Vice versa, normally this space is absolutely empty. It doesn't contain absolutely any liquid. How you can see it in X-ray? If you will make X-ray, I'm not sure if I put it here or not. If not, I will draw it for you. Then you make the X-ray, guys. You see something like this. This is our pleural sac. If it is, X-ray can be positive or negative. Yeah, in the positives, you remember. In the negatives, the bones is white, the air is black. Yeah, that's it. You can understand. That's it. Upwards here, you can see black air accumulation, but inferiorly you can see absolutely free space without any. Then there are liquid, guys. You see cutting lung. That's a untransparent structure for the X-rays cover this space, and you see horizontal level of the lung. Why? Because liquid is not transparent for the X-rays. Let's say you find the dense substance like the bony substance, white color in inferior parts of the pleural space, and absolutely horizontal level. Normally your lung has the sharp inferior margin like this. If you don't recognize it, it means inside of postdiaphragmatical sinus there are liquid. And this liquid horizontally make untransparent your lungs for the X-rays. They cannot pass through the liquid. So they show the white color. Idea is understandable for you guys. Remember it, please. This is very important. Let's continue. Third portion of your parietal pleura. It's called mediastinum. This is the part of the pleura which is separated from right and left mediastinum. In its turn, it's covered by endothoracic tissue, which you see. They say this is the most medial portion of the parietal pleura, which is separating pleural space from the medial side and border it from the mediastinum. Place of the transition of your costal pleura to the mediastinum, we call costomediastinal sinus. By the way, will be two costomediastinal sinuses, anterior and posterior. Costomediastinal anterior sinus and costomediastinal posterior. Place of transition of your mediastinal pleura to the diaphragmatical will be called mediastinal diaphragmatical sinus. For example, you can see here mediastinal diaphragmatical sinus. This is costomediastinal anterior and posterior. This is postodiaphragmatical deepest one. You can see it also in transverse section. For example, here, this is sinus between diaphragmatical and mediastinal from right and from left. Let's say remember once again, guys, all sinuses, deepest one, costodiaphragmatical, costomediastinal anterior, costomediastinal posterior, and diaphragmatica mediastinal sinus. By the way, to tell the truth, the practical meaning from all these sinuses has for us the costodiaphragmatical one. All other sinuses is small and generally doesn't contain liquids, yeah, and practically doesn't use for some investigation. But costodiaphragmatical is most important sinus. You will not only diagnose here the problem, but you will make puncture of this sinus and you will evacuate it the liquid, not only for diagnostical purpose to understand which kind of liquid is it, but also for treatment, to make the decompression inside of the pleural space, to prevent dislocation of the organs. Let's say this is very, very important, guys, remember please, but we don't mention the last fourth part of parietal pleura. I mentioned about costal, mediastinal, diaphragmatical, but here is the fourth. Fourth we call the cupola of the pleura, or the dome of the pleura. This is uppermost part of the pleura parietal. Parietal, which is come to our neck region, and as you remember, it is bordered from down our scalenvertebral triangle. It's located more than 2 centimeters upwards from your clavicle, and it is covered the apex of the lung. Let's say, remember, please, this is the parts of our parietal pleura. And in the transitional place between 1 and 2nd, we have formation of the sinuses. Right, please, the borders of the pleura. Last time I tell you about inferior borders. Now we'll draw, do you remember when we speak about projections, I told you, or in new slides I updated. As I tell you, take, because in the new slides I included information about projections, about landmarks, which was absent in your edition that I take once again. Now, right, please, parietal pleura has 4 borders: superior, inferior, anterior, and posterior. Superior border you know very well, right, please, 2 centimeters above the clavicle. It is the projection of the cupula of pleura. Inferior border described by the imaginary lines. Described by imaginary lines. Right, please. According to the middle clavicular lines, it is the level of the 6 ribs. According to the middle axillary lines, this is the level of the 10 ribs. By the vertebral lines, it goes downwards, and it is located in the level of 11 ribs. 12 ribs. By scapular line, 11 rib. By scapular line, 11 rib, and by the vertebral, paravertebral lines, it is the level of the 12 ribs. Let's say from 6 up to the level of the 12, guys. Remember, please. You can see here, the more posteriorly you go, the more inferiorly come to inferior border. Middle clavicular level of the 6, parasternal middle clavicular, 6 one. Then middle axillary, the 10 one, then the scapular line, the 11 one, and vertebral, paravertebral line, the 12 one. Let's say the more you come from anterior to posterior, the more descending inferior border of the parietal pleura. Right, please. Anterior border of the parietal pleura. In the right and left sides is asymmetrical. because of shift of the mediastinum and heart to the left side. Meaning attention in the picture, guys. What does it mean anterior border? It is the cross point between costal and mediastinal pleura from anterior. Yeah? The place where the mediastinal anteriorly become to the costal, or vice versa, call how you want. But you understand, guys, that in the left side, due to the pressure of the pericardium and the heart, this pleura will be shifted into the left. Let's say we have little bit asymmetry between anterior border in the right and anterior border in the left. Right, please. In the right side, it is more or less vertically descending line, which is started from upwards, from the level of the poststernal joint. Sternoclavicular joint. Sternoclavicular joint. It is descended to down, up to the level of the fourth rib, by the right margin of the sternum. Then it is come to the midpoint of the fifth rib cartilage from the right side. And by parasternal line, it is reached the level of the sixth rib cartilage. Right and look in the picture, please. Let's say you start from upwards in the level of our sternoclavicular joint. Above it, we have two pleura, not anterior border. Then you can see that without approximately changing of position, it is reached approximately up to the level first, second, third, fourth rib. Then it is start to little bit goes from the left to the right side. And finally, in the level of the sixth rib, it is finished by parasternal line. From that level, anterior border will become to the inferior border. You remember 6, 10, 11, and 12. So once again, sternoclavicular joint without changing of direction, the level of the fourth rib, then little bit shift from left to the right line, and finally in the level of the sixth, by parasternal line, it is the cartilage level we finished. Right, please. In the left side, it's also start from the same level. It is the level of the sternoclavicular joint. Then it is continuous up to the level of the fourth rib, again without changing of its position. And then it is pushed from right to the left side. But by the way, guys, just one improvement. In the right side, not by parasternal line, but by sternal line, sorry, the level of the sixth ribs. I'm very clear. Level of the sixth rib by the sternal line. And in the left side, right, please, it is cross the midpoint of the cartilage of the fifth rib. And finally, it is come to the cartilage of the sixth rib by parasternal left line or 2 centimeter laterally to it. By parasternal left line or 2 centimeter laterally to it. What does it mean? If in right side, guys, we finish our border by sternal line, in the left side, due to the shift of the mediastinum into the left side, we come or by parasternal or even more. I want to remind you, guys, that apex of your heart projected by middle clavicular line in the fifth intercostal space, 1-2 centimeter deep. It will be the same point of the projection of the anterior border of the pleura. They will attach to each other. Let's say, or it is, I say, not so much left parasternal line, but 2 centimeters laterally. If for apex of the heart, it is 2 centimeters medially to the middle clavicular line. For the pleura, it will be 2 centimeters laterally to the parasternal line. Idea is understandable for you. So remember this. Another borders, you know, I say inferior borders, 6, 10, 11, 12. Posterior border, right? Posterior border. But before write the posterior border, 1 minute attention to me. If it is possible, again, come to me. You have a higher guys, look to each other. Now look, I'm the heart. I push from right side to left. I push its anterior border. Anterior border come to the lateral. Now look, don't do anything. Now look what is happened with his opposite shoulder. Then anterior border goes to the lateral in the left side. Posterior border comes to the middle. He doesn't change his position. He's located strongly in its place. I push only the left sac. I push the left sac anteriorly from medially to laterally. Posterior border come from laterally to the medial. Thank you very much. Let's write, please. Posteriorly from the right side, border is passed strongly by the thoracic costovertebral joints. This is strongly in the right side, costovertebral joints, and we have the place of transition of the costal to the medial. But in the left side, guys, it's come more medially, look to me, to the anterior lateral left surface of the vertebra. Let's say instead of the costovertebral left joints, it is come to my anterior lateral surface. Do you understand me? Say right, please. Posterior left border shifted to the medially due to the heart pressure again, and it is projected in the anterior lateral surface, anterior lateral left surface of the thoracic vertebra. In the brackets, write please 1-2 centimeter medially to the left costovertebral joints. 1-2 centimeters medially from the left costovertebral joints. That's all. Today, guys, I think it is more than enough. Please, in the home, only one point I will describe you in this mediastinum. Read, please, division of the mediastinum, read the content of the mediastinum. Of course, in the practical class, we will discuss this question. And immediately next practical, and next lecture, we will speak about surgeries of the class. I think in the practical, in the lecture, I will finish it, and in the practical, why not? Let's start today. By the way, from the thorax, I forget to mention, you will have control. You will have control, that's a next practical class. If in my lecture, I will finish all these mediastinum and surgeries, next week practical class, you will have control work. Is it understandable for you? Yeah, if not, we will delete. If not, we will delete. Group numbers. 1 group. And today, day 7. No any noise, guys.